As chair of Summa Health, I am honored to be able to participate in this Akron Roundtable presentation. The Akron Roundtable being an organization that has earned a very richly recognized position as promoting dialogue and debate on the topics of concern in this community and nation. And healthcare is certainly one of those topics. And it is my pleasure to be able to introduce today the President and CEO, Dr. Tom Malone of Summa. I know for many of you, this will be your first opportunity to hear Dr. Malone speak since he assumed his current position in January of this year. As you can imagine, these past few months have been very active, and he has been busy with several key initiatives. Among those are assembling a new leadership team, moving the executive headquarters from the campus of Akron City Hospital to the Corporate Service Center on Gorge Boulevard in order to highlight the move of our company from a hospital company to a population health management organization. He also has overseen the creation of one unified medical staff to standardize care across our system. And by updating the name of the parent company from Summa Health System to Summa Health to reflect our focus today on caring for the overall health of our population. In a moment, you are going to hear Dr. Malone give you a talk about the current state of the healthcare industry, the changes that he believes must take place across the industry to ensure the continued health of our community and our nation. And a few examples of what we are doing at Summa to support those changes. I first met Dr. Malone when he joined Summa in 2013 as Chief Operating Officer and President of Akron City Hospital. And what stood out to me then, and does today, is his passion for medicine and his desire to help others. I believe that those things allowed him to hit the ground running as President and CEO. His pace is both fast and focused. His resolve to do the right thing for the health of our community is strong, and I can tell you that he will not shy from any challenge we face on the journey to transform the delivery of health care. That journey will take some time, but I am confident going forward with him that we will find it both rewarding and exciting. And now it is my pleasure to introduce Summa's Chief Executive and President, Dr. Tom Malone.
Thanks, Jim. He's never been that nice in the boardroom. So I'd like to thank Mike, David, and Akron Roundtable for the opportunity to meet all of you today. As Jim said, we've been doing a lot at Summa to really get prepared for population health. And so it's my first opportunity to meet a number of you. I wanted to give you a little overview of my background, just because it's my first time meeting many of you. I grew up in Niles, Ohio, not too far from here. That was a plan. I hate it when my mom does that. I went to undergrad at John Carroll, Ohio State Medical School, the Ohio State Medical School, I should say. Did my pediatric residency there, my neonatology fellowship at Brown. And I practiced neonatology for roughly 18 to 20 years, but really wanted to get back on the business side and administrative side of healthcare, and got my MBA at Notre Dame when I was practicing in Detroit. And really over the past couple of years was looking for an opportunity to really be in a position where I could impact changes that needed to happen in healthcare. I came back to Ohio back in October, as Jim said, and I really came back here for two reasons. One, professionally, I felt that the Akron community as a whole in Summa was really positioning itself to move towards population health at a time when healthcare really needs to move in that direction. And second, I'd say personally, it gave me an opportunity to move back home. My mom is 83, still lives in Niles. My sister lives in Warren, so it's an opportunity, I think, to reconnect with them. It's kind of interesting, back when I was interviewing here at Summa. I remember going to breakfast with my mom, and I said I was interviewing at a job in Akron, and she said, geez, when you left and you went to Detroit, I asked you why you wouldn't look at an opportunity closer to home, and you said you'd move back to northeastern Ohio when hell froze over. So I guess you can blame me for the last 2 winters. But really, I think if we talk about healthcare and we really want to frame the discussion, if I was going to pick one word to describe healthcare, the word would be disruption. Right now, we're in a state of chaos. And really the reason we're in a state of chaos is because the federal government has pretty much said that Medicare, first and foremost, the way we pay for it is unsustainable. The cost curve and the way we pay for care when you're sick and try and rescue you isn't working. And if we keep the current state of affairs for healthcare, especially in Medicare, we'll bankrupt the government. So something has to change. Second of all, through the Affordable Care Act, we've seen a lot of push towards Medicaid expansion. And really, Medicaid expansion is allowing more and more people to be covered on insurance, which is a good thing. But what's happening with Medicaid is really the only way states are able to afford the expansion of Medicaid is with federal dollars. And so what we're seeing on the Medicaid side is the federalization of Medicaid. And more the federal government is paying for Medicaid. And so 80% of the Medicaid expansion in the country is coming through federal dollars. And if you take a step back and say, well, if Medicare is unsustainable for the federal government, and we're adding more and more Medicaid through federal matching dollars, how are we going to afford that? Well, we can't. We're going to break the system even quicker. And if you add in the fact that most Medicaid plans, especially like the ones in the state of Ohio, we're recreating a fee-for-service model that's broken, and that the federal government said has to change. And so that's why we're in a state of disruption, because 60% of the revenue that comes into healthcare facilities right now comes from the federal government. And it'd be nice if we could go back to you all and say we're going to raise your taxes to afford care, because what we have is really good. But what we don't have is really good, because all the money we're paying, the screenings for colonoscopies, for mammographies, vaccination rates are lower than our national competitors in Europe and everywhere else. And even in the state of Ohio, we have the 47th worst infant mortality rate. So obviously the cost of what we're paying for isn't there. And so if we want to go back and raise everybody's taxes to keep the current mess that we have, it's really not going to resonate with the voters. So that's why things have to change, and things have to change quite quickly. So what's the solution? Well, first of all, if we can't afford health care right now, it's because we're too costly. And we're too costly because those of us providing the health care haven't figured out a way to do it more efficiently. And one of the reasons is we don't coordinate things, but more importantly, our cost structure is too high. And if we look at where we need to go for affordable care, we have to take hundreds of millions of dollars out of the delivery system in order to get to a cost place that's more affordable, not only for us to survive, but for you to pay for health care, because co-pays and deductibles continue to go up. So we need to move away from just investing in buildings and hospitals and really start laying the groundwork for where we're going. A key component of that is going to be a strong information technology system that allows us to share information and data real time to drive changes in healthcare. The second thing we need to do, which is very difficult, is to eliminate duplication of programs and resources. And so every hospital has the same thing, but it's unaffordable, and we're all spending the same thing on the same technology. And so we have to stop duplication of those programs which drive costly technology. And then the third thing that we need to do is really focus on clinical efficiency. We need to do a better way of ordering the things that we order. We need to get rid of variability in care by having standardized ways of delivering care. And we also need to give the right care at the right place at the right time, which is usually not in the hospital. Right now, 90% of care is outside the hospitals. Yes, we invest most of our money at the hospital level. And that's going away. More and more care is going away from the hospitals. So we need to move away from volume and try and drive value. And you hear that a lot. But really, value is defined in healthcare as the triple A. It's improving the experience of care for individuals. It's improving the health of populations. And it's lowering the total cost of healthcare. And it's lowering the total hospital so we can survive as a business, but it's also lowering the total cost of healthcare so when you have a copay and deductible, you don't go bankrupt before you even get your insurance. And those of you who've got on the exchange are realizing that the only way you can get on the exchange is you have a high deductible or a copay, and it's unaffordable even when you go and seek care right now. So we have to remove that barrier to care. And the key to delivering value is a concept called population health, which we talked about. And people always talk about population health, but they talk about it in a very generic way. And it means different things to different people. And that's why it's been so hard for people to try and figure out what is population health. Population health for me is really care coordination. It's coordinating the total care of the patient. And there's two key concepts that are vital to the success of care coordination. The first is an accountable care organization, and the second is a patient-centered medical home. An accountable care organization, they began in January of 2012 after the Affordable Care Act was passed. And what the Affordable Care Act did was it allowed all of us who used to compete with each other to start working together on new ways of delivering care for Medicare recipients. So hospitals, doctors, nursing homes, rehab centers could all start coming up with a continuum of care and a new way of delivering care that if in the long run works, we can share in those gains. In the old days, there were regulations that didn't allow us to do that. So what an accountable care organization is what it sounds like. You're going to be accountable for the care of a certain population. And in this particular case, it's Medicare recipients. And that started in 2012 and gained a lot of traction. We're going to talk a little bit about that in a couple of minutes. The second piece is patient-centered medical homes. And what a patient-centered medical home is it's a team-based approach to care. It's physicians, nurse practitioners, mid-level providers, pharmacists, social workers, everybody working under the same roof to give you a whole way of delivering care. So you don't take care of a patient based on their disease, like you're coming in for congestive heart failure. You're taking care of the whole patient. So it's like your second home because they know everything about you. In the current world, when you go into your doctor's office, doctor that you may be seeing for 20 years, the first thing that comes out of their mouth is, why are you here? Second thing is, what medications are you on? Really? You don't know what medication? I've been coming here for 20 years, you don't know what medications I'm on. But yet if you order a pizza, they know what you ordered last time. There's something wrong with it. So what a patient-centered medical home is they all know everything about you. And right now, if you're on the list to come into a patient-centered medical home, they're reviewing your case before you come in. And so when you come in for your congestive heart failure, they sit you down and they say, we know you're on these medications. Has anything changed? Why are you in here today? But the difference is, rather than taking care of your congestive heart failure, the second thing they'll say is, oh, by the way, you haven't had your mammogram yet. We're going to schedule that before you leave the office today. And oh, by the way, we're going to call you the night before your mammography is scheduled to make sure you go for that. And 5 years down the road, I'm hopeful that I can arrange transportation for you to get you to that mammography so that we make sure you get your screening test. That's the difference between managing the whole patient through a patient-centered medical home and really just managing you when you come in for your episode or your disease. Right now, through our ACO, we have 42 patient-centered medical homes around the community, and there's a lot of other healthcare systems around that are developing these medical homes because they are the benchmark of where we're trying to go for population health. The other piece is that if we're going to go from volume-driven to value-driven, we need to move away from the old concept of margins being based on how sick you are. And so in other words, all of us really developed things based on what we were paid on. So we all have centers of excellence in cardiology, neuroscience, orthopedics, because when you're sick and you need surgery, that's what we get paid the most for. So that was a great business model. It just doesn't work and it's not affordable. And so if we're going to move to where we need to go, we need to lay the foundation for population health. And if we're going to do that, we need to redefine what primary care means. And for me, primary care is expanding in population health. And it's moving from just the old concept of internal medicine, family medicine. It's also including mid-level providers, physician extenders. And that's the first piece. But really, as the population ages, geriatrics and geriatricians become important from a population health management because we get chronic diseases and the complexity of the chronic illness is different as the population ages. The third piece of that puzzle is women's health, because nowadays most women, especially early in their career, really want to get their primary care from their obstetrician. And many of the new obstetricians that are training really want to deliver that primary care. And lastly, behavioral health. And behavioral health is an important component of population health. And if you look at Medicare patients, where the data is coming from our ACOs, 60% of people who seek medical care also have a behavioral health issue. That's staggering to me. Okay? And it's not because they need to be hospitalized for a psychiatric problem. It's depression, it's anxiety, it's questions that they have that they need to deal with. And we need to screen for that in the primary care setting. Doesn't need to mean that we need a psychiatrist in primary care, but we need social workers, we need psychologists in the primary care settings if we're really going to do population health right. So it sounds great, but why isn't it happening? And the reason it's not happening quickly is because healthcare is a very tough place to make significant change because we're very traditional. We've been in a fee-for-service model probably for the entire century, and so changing on the pace that we need is very difficult. The other thing is, as much as I've been out in the community and everybody wants affordable health care, when we want to make changes to a facility or program that's in the community, they say, oh my God, you can't take that away from my community. But we have to, because people need to understand that looking at that hospital and the bricks and mortar isn't where the care is being delivered anymore. It's being delivered in ambulatory care centers. It's being delivered in your home sometimes. And so we need to think of things differently as a community. Commercial payers, big commercial payers like MMO, Aetna, Humana, they don't want us to get there that quickly. Why don't they want to do that? Because right now they get paid every time I call them on the phone to ask if it's okay to do an MRI. An ACO, you just give me the risk and I'll figure it out. Okay, we don't need to call you anymore. So we get rid of that margin, which is money we're all paying for, and we add value to the bedside. Well, if you're a commercial payer, that is eroding at your margin. So you got to figure out how you're going to play in this game, or all you're going to do is process claims. And so they're trying to figure that out, but they're slowing the pace of change in order to figure that out. Also, I think right now, because the pace of change has been slow, about 20% of our payment is in the new payment, the value-based payment through ACOs, and about 80% is still in the fee-for-service. In order to make this work, we need about 30 to 45% of our payment in a value-based model. And so right now, it's more profitable to stay in fee-for-service. But we know if we don't jump the curve, we won't be ready for it. So during the transition, most of us are going to have a tough time because we're investing in stuff we don't get paid for. Care coordination, care management, the insurance company gets paid for. So right now, they don't care if we're investing in that. And the second piece is the big margin business is cardiology, neurosciences, like we talked about. So while I'm investing in behavioral health, geriatrics, primary care, it makes us all feel good, but there's no margin there. And so if most healthcare companies get a margin of 3%, and over the next 2 to 3 years during this transition, we're going to be investing in things that aren't reimbursable. I've got to have a very patient board behind me that understands where we're going because it's going to get a little hairy while we're making this transition. And so that's why it's difficult, I think, for larger companies to make the move. And I think lastly, there's still a perception in Washington that things will change based on the election, okay? Like by some ray of hope, the funding will change. It's unaffordable no matter who's in office, so it's got to change. So why will it happen? I do think accountable care organizations are proving there's a better way to deliver care. And if you look at what's happened nationally, most of them have saved. If you look at the composite, over $100 million for Medicare over the last couple of years, and they've also improved the quality. Our new health collaborative, our ACO at Summa, had 25,000 Medicare recipients that they were at risk for. And over an 18-month period of time, they were able to save $12 million of spend compared to the previous 18 months on those Medicare recipients. So we saved $12 million, we got to save 6 ourselves, and we gave 6 back to the federal government. There are currently 744 ACOs around the country, and the fastest growing ACOs aren't in the Medicare space. They're in the Medicaid space and they're in the commercial space. In the commercial space, it's from some of those large insurers who are trying to figure out where they're going to go. So all of this infrastructure is in place. They're saving hundreds of millions of dollars and they're improving quality. It doesn't matter who gets elected in Washington. The train's left the station and we're going down a path of population health because it's a better way of delivering care. Medicare and Medicaid, which provide 60% of our funding, is going to go bankrupt. So again, they want us to change. Self-funded employers, many of you around the table have self-funded plans. I'm interested sometimes because I even talk to some of my colleagues in the healthcare industry. We have a self-funded plan here. And everybody says, well, we don't want to get into a risk contract. We want to avoid risk, because if we get into a risk contract, we could lose our shorts. I didn't mean that based on the article in the paper this morning. That just came to me, I'm sorry about that. But basically, every self-funded employer plan for healthcare is a full risk contract. It's an open checkbook. And what self-funded health plans want is fixed cost. And so what they want to do is eventually partner with an ACO and say, I want to know what my cost of healthcare is going to be next year. And if you get it in less than what we say, you can share in the gains. And if it's more than that, then you take the risk for that. And the whole point of this ACO structure that we're putting in place is that we're gaining experience on where we're trying to go, and so that we can sit down and expand that volume, and we can sit down with you and say, now the experience has been expanded. So at Summa, we're taking what we learned on our ACO and our Medicare population, and next year our employee health plan is only going to have one health plan, our ACO. You can only go to our hospitals. You got to be managed in a patient-centered medical home. And what we want to do is gain experience from that and keep learning from that experience to re-engineer the way we're delivering care. So that when I sit down with some of you in this community, I can say, based on our Medicare experience and our own employee health plan, look what we were able to do on quality and cost, and we want to partner with you now. Consumers on exchanges, they want transparency and they want low cost and quality too, because again, they have high deductibles and copays. And lastly, I think at the heart of it is, this is why I went to medical school. I mean, this is a better model of care. Because really, coming in and just being seen when you're sick, and nobody really cares about you in between those episodes, is not a good way to deliver care. And I think most of us, whose vocation is healthcare, really see that this is where healthcare needs to go. So what does this mean for you all in the next 3 to 5 years in the Akron community? I think what it means for you is that you're going to have an opportunity to help us redesign healthcare. And you're going to do that one of two ways, I think. Number one, partnering with us, if you have a self-funded plan, partnering with other ACOs to try and figure out if we can come up with a better way of delivering care. And I think many of you are also going to be cared for in a primary care medical home, and you're going to see the value of doing that, and you can be ambassadors for us to spread the word on why it's a better way of delivering care. I think you're going to see continued consolidation and integration across healthcare, because we have to develop scale if we're going to get more efficient. So there's no question about that. But consolidation doesn't necessarily mean mergers and acquisitions. We have a minority partner in Mercy. We did that because they were willing to invest a certain amount of money with us, and at the time, it gave us the stability and the cushion so that we now can invest in all the things that we talked about that aren't big margin business so that we can jump the curve. And at the end of this, we will still be independent, they will still be a minority partner, but because they also have a statewide network, they're also going to be on the same IT platform with us. Now we can have a statewide ACO to scale that risk and really deliver care. And so that's the reason that all of these mergers and collaborations start. Right now we're talking to some competitors of ours about areas that we can actually collaborate in because it makes sense business-wise in that sector of the business, even though we're competitors. So you're going to see a lot of that integration, collaboration over the next few years. You're going to see reallocation of resources away from the hospitals into ambulatory care centers. There are going to be consolidation of inpatient hospital beds because we're overbedded in this community. That has to happen because it makes us more efficient, but also if sicker and sicker patients are only getting into the hospital, those caring for the sicker and sicker patients have to see enough patients in order to be good at what they do. You can't do this once in a while. And so that's why there's consolidation on the inpatient hospital beds. And really, if you think about it, it's a lot what happened in pediatrics years and years ago. I'm a pediatrician, neonatologist by training, but almost every community hospital had a pediatric ward. And they had a pediatric ward because you could take care of asthma, gastroenteritis, and some of those things on a regular floor. And then when we got better at taking care of those things, and we got better aerosols, and we got better immunizations, all of that bread and butter stuff went away. And only the sick patients came into the hospital. So you pretty much needed a pediatric ICU or a neonatal ICU if you were going to deliver pediatric care. All the pediatric hospitals, community places went away. And now we have big community tertiary care pediatric hospitals like Akron Children's with a wide base of referrals that they get in because only the sickest patients now are going to the children's hospital. That's the same thing that's happening on the adult side right now. As congestive heart failure, asthma, chronic disease starts getting managed in observation and in the home setting, the bread and butter cases that used to go to 50-bed community hospitals isn't happening anymore. And so that's why there's a consolidation. And it's going to happen regardless of whether we want it to happen or not because we're caring for patients better in a different environment. All of you will be up to date, I'm hopeful, within 3 to 5 years with your colonoscopies, mammograms, and vaccination because you're going to be in a patient-centered medical home. None of us, Summa, Akron General, Akron Children's, will look the same in 3 to 5 years. We have to change if we're going to survive. More than half of you will check your care through your medical record, your electronic medical record, which you will have access to. You'll check your lab tests. You'll see when your next checkup's regularly scheduled. And most of you will use an app on your cell phone to improve your health care. There's no question in my mind with where we are in healthcare today, it being very disruptive, that new competitors will come into the market. CVS is now CVS Health. Walmart wants to start its own insurance company. We're going to have to find a way to collaborate with these folks in order to include them in the continuum of care. So in conclusion, I hope I have given you a better understanding of where I think healthcare is going. Summa is all in on this population health strategy. We know we need to get there quick. We think we're going to get there quicker. I think I have a great team in place that's going to help us get there quicker. And I am looking forward to working with all of you on this journey towards population health. So thanks for your time today, and I hope you have some interesting questions other than our dress policy. Thank you.
Our speaker has graciously agreed to respond to your questions. As mentioned previously, please feel free to use your mobile devices to send questions. Instructions for using Ask Her are in the brochures, and I know we already have a number of questions that have come in. Also, there's note cards on your table if you prefer to write your question down. Hold up those cards, they'll be collected so that they may be presented. I now invite David Hunter, Program Chair for the Roundtable, to review our questions.
Just to respond to our speaker, we do have some very interesting questions that do not relate to the dress code policy that was in the paper today. And we also have some very interesting questions that do address the dress code policy that was in the paper. But we'll start off with this question. Is there a specific example in the U.S. or in the world, a city, a region, or a country, that is a great example of a successful health system?
I think the places that have probably nailed population health the best are probably Kaiser on the West Coast and Geisinger in Pennsylvania. And they've had a model that's been similar to the model that everybody's trying to get to for quite a while. I mean, it takes some tweaking, but they really were into the value-based model a long time ago. And so I think they're kind of ahead of the curve When I came here and I heard about, the accountable care community that Akron was starting, and I think we're on that journey now, I bring that up because when I think about Medicaid and where Medicaid needs to go, the only way we're really going to solve Medicaid is by having an accountable care community approach to Medicaid, because there are so many things. We talked about behavioral health, but more importantly than that, so many social issues that need to be dealt with in order to keep patients out of the hospital and improve their care, that if we don't use those community resources as part of the healthcare system, we're really not going to be able to really have an accountable care organization. So I bring those 2 points up.
We have 3 highly competent, award-winning healthcare facilities that are headquartered here at Akron. And there are quite a few questions that relate to those 3 institutions and how they interrelate. That's always been a topic of interest by our community, and it's carefully monitored and watched. Some of the questions talk about how we can get cost out of the system relating to what you said during your remarks. Is there some overlap here between these 3 systems? Is merger a solution? So I think the best way to phrase the question might be like this. How do you assess the current relationship among these 3 institutions? And in what ways would this 3-way relationship need to change to ensure the very best for our region and the patients they serve?
And world peace? I think, we're on a journey, so I don't think anybody's had this figured out. I think Children's is a little bit different. They tried to be Switzerland as much as possible to their approach to healthcare, and I think it's worked for them. The clinic coming in town, I think, is good. I think they're going to raise the bar on competition, which makes us all better. No question about that. And I think we need to figure out how we all fit in the population health. I mean, I think the clinic's model has been a fee-for-service driven model, but very quaternary and very good at what they do. And whether they move down the bundle payment route to fitting in population health or how they do that's going to be interesting to see. But, I think at some point we need to have a rational discussion, at least in the community, on certain things like trauma. And really, does it make sense to have 2 trauma centers? And that's not an easy discussion. But I do think as finances bring us closer together and we see the cliff that's upon us, I think making some of those more difficult decisions as a community are going to be easier than they were in the past. So that's where I think I'll leave that one.
One member of our audience asked this question. I love the idea of combining primary care with OB visits. When is that combination likely to be available in Akron, and what are the barriers to doctors making that change?
Well, I think, we have been pushing for that model in our OBs, and not all the OBs really want to do that, but some do. And so I think the model is there, and it's certainly evolving. I think it's really, docs are now trying to figure out, how they best fit into the new model of care too. And, when I mentioned the 30 to 40% switch in payment being important, it's important more on the provider side, meaning the physician side, than anything. Because if you're still paid 80% based on the number of people you have in your office, and I want you to pay attention to the 20% that are being paid differently, you really aren't going to do that. You're going to just do the same thing you do on the other 80% of the patients. But if there's enough at risk for you to change your behavior, which usually happens about 40% of that revenue stream, then you can change behavior. And so that's why we're pushing to get that model changed. And I think you're going to see more and more of that primary care being dealt out into the different areas. In a perfect world, like I mentioned in a patient-centered medical home, in a perfect world, you could show up at your urologist for a urology exam, and they would schedule your mammography. Okay? Nowadays, your urologist is saying, hell, I ain't ordering that because you'll give me the results and I don't know what to do with that, right? And so the new model of care is that we all care about your primary care.
Another member of our audience poses this question. Of course, it's been noted that Summa is the largest employer in Summit County, so it's logical this question would be asked. How would you respond to a question inquiring about the community commitment that Summa would have to the greater Akron area?
Well, people ask me what keeps me up at night. a lot of things. But being the largest employer does keep you up at night, because if you don't do things right, and your largest cost is employee, the way you have to cut costs is a lot of times, consolidating and reducing your workforce. And so, well, one, we have a commitment to the community. My commitment to the community is really having the most viable business that I can possibly have to keep everybody employed, because we are the largest employer. And then I think because we have such a committed workforce, we have so many people volunteering in the community to do different things, that we are a vital part of the community, and it's very important. When I brought up that people get married to bricks and mortar, that's the piece that I think they see. They see the hospitals, no matter what community they are. In many communities, the hospital is the largest employer. And so they say, well, if we're changing the hospital model, or if we're closing beds, or we're changing a program, then we must be laying people off, or we must be reducing care. When in actuality, all we're doing is changing the roles of those individuals. They're still gainfully employed, because we're changing with where healthcare is going. So I think people need to understand that most people aren't going to be employed in the hospital. They're going to be employed out in the community as population health grows, but they're still employed by us, and they're still going to be contributing to the community. So that's an important thing for people to understand, because I think every time we want to make a change, it's perceived as a negative and a takeaway from the community, when actually it's a positive.
The centerpiece of your remarks, of course, was on population health here. Another member of our audience would like you to comment on what the appropriate role of government would be in population health going forward.
The appropriate role of government. How do you? First of all, I'd say the role of government has been, to be quite honest with you, because it's unaffordable what we're doing, and 60% of our payment comes from some form of government, either state or federal. They have really said and have been the impetus behind the change. The second piece of it is, they've done regulations to help move us in the direction we need to move to. And in typical government fashion, the talk is all of the regulation that needs to happen in order to make sure that we get to where we need to go. And really what I'd like to do is, now that we're moving down that road, I'm hoping that the government's going to allow us to figure it out through the accountable care organizations, and really not have too much regulation, and with a layer of cost and everything that's going to go there. But quite frankly, without the Affordable Care Act, it's not a great act. It has a lot of things that are good and are bad. But without the Affordable Care Act, we wouldn't be where we are today. And if we aren't where we are today, we wouldn't have a sustainable chance at really nailing this, because nobody was moving in this direction, even though it was unaffordable. And I think government should be applauded for that, because they moved us down the road a little quicker than any of us were willing to go.
Your response to the last question is a good segue to this next one. A member of our audience poses this question: what do you like most, and what do you like least about the Affordable Care Act?
What I like most about it, I think, is when it set up the ACOs. I mean, I think allowing the ACOs to be innovators in where healthcare is going, I think, is great. And the fact that we have 744 of them. I've been at government-sponsored talks where we've been sharing our experiences, and we're all learning from each other. So I think that's been a wonderful thing. What I don't like about the Affordable Care Act is right now the exchanges are difficult at best, the way they work. And I think the ability to have people go on the exchange and have really affordable care is kind of difficult right now. And so I think the whole exchange piece needs a little work.
We have many more questions, and this Ask Our system is working really well, so I'm glad to be able to say that. But I do want to turn our attention to today's story in the Beacon Journal, if I can. Could you offer some insight on what led up to this and the process that Summa followed on this, and how would you respond to those who think that this change seems to single out women perhaps a little bit more restrictively?
have you been to Walmart? People who left the house actually thought they looked good some days. Okay, so our point is, I'm sorry, but that happened. Seriously, it doesn't focus too much on women, and really the reason it seems to focus more on women is because a large portion of our workforce in healthcare is women. But really, for me, the thought process is there should be a certain level of professionalism at a healthcare institution that's a little higher bar than at other places. And the reason for that is we're delivering care, but if you put yourself, at least in the hospital setting, in a bed with no clothes on and a robe that opens in the back, you're probably not more vulnerable than any time in your life. And when people come in and you're not sure who they are and they're not dressed very professionally, it makes you uncomfortable. And so all we're trying to do is standardize that, and it's tough to standardize it in a policy, so you take your best approach at it and you go from there. But I think most of us would understand that what we're trying to do is have that level of professionalism and safety. And I came from Detroit, and my COO followed me from Detroit. And we were in Detroit, we spent 2 years really on a professional policy, an image policy, and it focused not only on our employees, but even on our residents and our doctors. And I used to send people home if they were dressed poorly in Detroit. And I used to take pictures of them so I could show them at orientation on what not to look like. And after a year or so, nobody wanted to get their picture taken, and people started dressing appropriately. But, sometimes they just need to get it in order to try and figure things out. But, I don't want to take away from today's message too much, but that's kind of where we were, because this is so much more important than those kind of things. So.
What Summa is going through now seems to be what a lot of organizations are going through, is trying to create an appropriate environment in their workplace here. We have a lot of other questions about that we're not going to dwell on. I'm not going to follow up on the suggestion from one member of the audience about whether Summa might consider a new corporate tagline for the company that would adopt the Latin phrase "semper ubi sub ubi." Always wear underwear. But anyhow, back to a serious question. How about the future of gene therapy here, and how is Summa preparing for that?
I don't think we're necessarily preparing for what gene therapy is going to look like. I mean, being a teaching institution, having research done, and partnering with others who are doing that. I think one of the big opportunities is with gene therapy, and part of the problem becomes not with gene therapy, but with all the new things that are happening in the current environment. If you get a new drug, a new biogenomic or something like that, it's almost unaffordable. And it's even unaffordable for insurance plans to do that. And so, what we need to do as we move down the population health curve with the federal government is find better ways that when a new drug comes that is very valuable, is to find a way to make it better and better affordable, because that's a big problem with not only gene therapy, which right now is more research oriented, but a lot of the new drugs that are coming out are unaffordable.
I think we'll close with this question. We have several people in the audience who've been asking about the helpfulness, the validity of second opinions that people obtain. What would be your best advice to people asking about that?
Well, I think anytime anybody wants to educate them more on their disease, I think that's a positive thing. But what I think has to happen is that second opinion really needs to be coordinated through coordinated care in your patient-centered medical home. Nobody has a problem with getting a second opinion, but that needs to then be tied back to your whole care plan. So again, we can care for your whole care. Even if we end up sending you somewhere that's out of network for our coordination of care, because we don't provide that care, even the care that you're getting out there, we need to be tied into so we understand what's happening there, because you're going to come back and have other things happen. And so that's the piece of care coordination that we're talking about that's very important. But getting second, third opinions when you're really concerned about your health and you want to get educated, I think is important. When it becomes problematic is when there's different opinions, and then it becomes fragmented care, because then it's not good care.